Thanks. Okay, we are now recording. Let's hide this again. Great. Okay. Here's, all of those pictures that I showed you thus far were idealized pictures, right? And this is what it actually looks like when you look at the echo itself. So this is a short axis view, right? And then if you rotate it, you can get the parasternal view here, right? So this red line through the short axis, if we rotate the transducer such that that red line is now our imaging plane, this is what it looks like, right? If we angle our transducer and show the blue line as the imaging plane, then we can see what's on the right ventricular side, right? Over here. And if I go this way, we can see what's over on the left ventricular side. So it's a very, as you can see, with stationary pictures, it's often actually kind of difficult to understand what is what. When they're moving and they're cines, and this happens in real time, it's a lot easier because you can see the relative motions of things, and so it, gives you clues as to what's going on. And then, as I said before, the tech will, once they've centered up and they say, oh, okay, this is the right view that I need, they then just press a button and it'll record at that time, and then they lift, and then that's captured and put in the database that the physician will read. And oftentimes you wind up with 50 of those recordings, right? And so the physician goes through those, and they usually have a good relationship with the tech, so they know what's coming next, right? So it does the same thing every time, but it's something that gets built up over time. How you do that, which one comes next, how, what the settings should be on it, and things like that. Oh, this is a really cool video. I'm not sure why it showed up here, but so I'll also send you, or they'll be in here, there'll be links to some of the GE, Siemens, Philips sites where they show their best stuff, and some of it's pretty cool, and it's always changing. Like every year at the time of the big radiology conference, which happens the week after Thanksgiving, it's like the sync pulse for these businesses. Like everything happens on that week, half their sales happen that week. And so all of their new features get announced that week at this trade show, right? And so it's pretty cool. Like after that, you go through and see all of the options that all engineers have been working on all year. And one of these is 4D flow. So you're taking a 3D echo image. So we're sweeping now to get the 2D plane, and then you sweep back and forth to get the 3D plane, and then you turn on Doppler, and so you get basically a 4D velocity field, right? And one of the problems they were having is that when you do the color map, it obscures your view through the object, right? And so now in this application, they've put like real-time volume rendering with transparency on this thing. I think it'll go, yeah. So this is the old type, and it's going to sort of fade into this new volume rendering thing, such that you can still see this jet at every phase, of the cycle. And you can see it's, the issue with pure 3D ultrasound in some respects is the fact that if you can't go fast enough to get everything done in one heartbeat, which is usually the case, you have to count on the fact that the heartbeat, say for 3 or 4 beats, will be the same. So if you assume that, say the person's heart rate is 65 and it's locked, it's just the R to R is exactly the same, the time between QRSs, then things should be okay, right? Because that means if the timing is identical, the volume of blood that is brought into the left ventricle on each beat and the amount ejected is stable. And you know, for a stable, normal person, every beat is pretty well the same. It's quite remarkable. When you do flow velocity in MR, which takes, say, 32 beats to acquire the data, you see these coherences in the flow pattern inside the ventricle that must be repeated on every beat in order to add up all that data to, you know, to get a coherent MR. And so it's pretty impressive how reproducible it is. Yeah.
So you cannot do this with atrial fibrillation patients, and you're monitoring the heartbeat, right? So can you time it so that you can sample the QRS?
That's right. So the question was, does this work, or it probably doesn't work, or maybe it's a statement, in atrial fibrillation patients? And the thing about atrial fibrillation patients is that their atrium has lost the ability to be the pacemaker of the heart. It kind of randomly fires. And so their R to R interval between QRS depolarizations is a random number. It has a mean of, you know, 65, but it's 65 plus or minus, you know, 20 sometimes, because sometimes the heart will sit there for a long time and not beat. That screws everything up, right? That screws up this type of acquisition, because each beat, if you give the heart twice as much time to fill, it will change its end diastolic geometry, right? It'll look like a different object on each beat. And then if it ejects really quickly after the previous beat, it doesn't have enough time to fill, so it's a smaller object when it ejects. The ejection will be smaller, et cetera, et cetera. So yeah, in atrial fibrillation, this becomes quite hard. At that point, you want to revert back to real-time type of stuff or single heartbeat imaging. The other interesting aspect of that is, and we run into this in CT a lot, say, well, I can do single heartbeat imaging, therefore I am, you know, protected from artifacts from atrial fibrillation. However, you have to then ask, what type of heartbeat did you image? Right? Now I've got a whole collection of heartbeats that this patient can deliver. Which one did we image? Did we image one that's a really short R to R, or one that's a really long R to R, or one somewhere in the middle, right? And so we've actually run into problems where we've imaged one of these really short beats, and it's not a natural looking beat, right? It's just a little twitch, right? And then, so that is not representative of what's going on in that patient's heart. So do you go back and do it again? You know, there's that question. If you had a smart algorithm that looked at the EKG and did a running calculation of the probability of when the next QRS is coming, which is conceivable, right? I mean, it is random, but there are patterns. Then you could say, okay, this is the most opportune moment to scan. And then sometimes you just give up and say, I'll just scan for a second. Whatever happens inside that second, that's our data, you know. So this is I mean, it's kind of a trick, right? Or it's not a new acquisition. It's just rendering the existing data that you have, because people were complaining they couldn't see through the darn flow field. But it you know, does. What's really amazing is the fact that you have this 3D valve in front of you and you see this jet coming through the valve. That's pretty cool. Oh, this is more. Let's see. Is this a video? Okay. Now I need my glasses. Put this up so they don't steam up. Okay. Let's see what this is. Okay. So here we've got. So it's interesting, right? When it's static, you look at it and you're like, oh, I don't know what that is right off the top of my head. And then when it goes dynamic, right, it's obvious what's going on here, right? So we have probably a mitral valve there, sorry, with these jets rendered, right? And then probably what we're gonna, sorry, this is marketing prep. But look at these pictures. I mean, that's beautiful, right? So you have in the central view here, in this thing, you have a 3D ultrasound with that flow map right on top of the valve plane, which is pretty cool. And then you can measure these, flow velocities as a function of time to get some indication of what is the peak velocity through a jet, what could be the pressure difference between the two sides of this jet, given that velocity. And you basically are trying to quantify the severity of the regurgitation, and is it required to put a prosthetic valve in that patient, given that physiology we've measured. So, as imaging scientists, we're all about signal to noise, accuracy of what the data is, et cetera, but then you map it to a number that comes out to say, do I put a new valve in this patient, right? And we'll see that kind of application as we go through some of these things. Here, this is basically demonstrating a parasternal view, again, of a normal heart. Well, it's a slightly dilated heart. And what's happening here is that the system itself will recognize what's going on and make measurements across the heart wall, and then produce, geometric calculations, geometric measurements, and also produce functional measurements. I think we'll probably go into, so there's some more geometry, and then given that line that you have defined with the geometry, you can then flip into M mode, and you can measure these dynamics of the wall and how it's contracting. You can imagine that not only the total dimension of how much ejection is occurring, like how one wall is moving away from the transducer, one's moving towards, how much is occurring. There are dynamics also in these derivatives, right? In the temporal derivatives of these curves, in that, is the heart contracting in a sluggish way, or is it twitching or aggressively contracting? And so some of those derivatives can be measured. And you can do that also with the velocity, as we'll see. So here's like some of the parameters that can be computed. Here we have basically a window within which we're going to compute Doppler values. And you can change that depth of the window, and then produce a picture of the velocity spectrum down a specific line, right? And so these velocity pulses here, right? You can look at the rate of ascent and the rate of decay of the velocity to come up with estimates of the underlying robustness or function, right? Again, most of these computations are now done automatically on the system, given this data, right? So you can see now you've got this many numbers measured to quantify that object. It gets a little ridiculous, right? Maybe that's too many numbers. Maybe we're overdetermined here. But you can imagine that each one of these numbers has a number of papers written saying it's the number to measure. Now this is through the aortic valve, right? And you can see basically the width of the pulse. We get to our peak velocity through the aorta, and then a decay as the pressure is reduced from the ventricle. So you hit your peak velocity of the blood going out the aorta. And then as the ventricle is finished contracting, right, it still stays at the end systolic configuration, and the blood starts slowing down, right? And so you can measure the decay rate of this to look at the basically the how much pressure is there downstream. Is this something that's easy to push and then it just shuts off when I stop the pressure, or is it is there a lot of decay in the way that the velocity slows down? Part of this, as you can imagine, is related to the compliance of the aorta itself, because you're pressurizing a tissue tube, and that tube increases its diameter. And then as the pressure goes down, the diameter basically is reduced. And how elastic is that object? When you're young, you have a very elastic aorta, and when you're older, it gets really stiff. And so this starts looking like a stiff pipe. And this is interesting. That's like a cloud. All right. So this is looking at left ventricular performance based on the valve, or I'm sorry, based on the volumes that you measure. So it has, you guys tried to do this, right? It automatically drew this contour. You know, this isn't a trivial thing in a lot of images, right? Normally there's a regularization achieved by making this a smooth object in 3D. You have a number of planes that you can image, and you can look at the heart at end diastole and systole and compute sort of performance by ejection fraction and things like that, and change of volume in time. So that first derivative of how the volume is changing in time, etc. You can see that the left atrium, it ejects, it precedes left ventricular ejection, and so the dynamics of the left atrium are somewhat important for sort of charging up the left ventricle. So you can actually increase the volume of the left ventricle by 10 to 15% just with the atrial contraction. It's not just a conduit. And then the left ventricle ejects and it fills up the atrium, right? So basically the valve plane is moving up and down as the atria fill and empty and fill and empty, and the ventricles fill and empty. When these stop contracting, then you have a dangerous situation where blood stasis can occur. It can get caught in pockets, and we'll see that application a little bit later. Okay, again, just to look at dynamic 3D echo when it works really well. You can see this. This is again a parasternal view, so we all know what this looks like from our experience 5 slides ago, right? So the transducer's up here. This is the aortic valve, and these are the leaflets in the aortic valve rendered in 4D actually. And this is the mitral valve, right? And down here's the left ventricle. So, you know, this is transparent because on the echo, it just doesn't have any signal. There's not a lot to reflect off there unless you did Doppler, right? And so you can render these up so they look pretty nice. The other thing is, you want to look at them in 3D because if they have some weird oblique shape and you're going to put a new valve in this person, you want to measure that geometry, right? To pick the right valve off the shelf, essentially. And again, here's the heartbeat. QRS is down, so it tells you at which phase, if you look at the little red dot, at which phase you're at. And this is normally an average of a series of QRSs that were used to make this 3D volume. Okay. This is an example of Doppler with a transducer that's put right onto the carotid artery, internal carotid artery. And so this is the patient's right and left internal carotid artery. And we've put a line through it and measured velocity as a function of time in order to make a quantitative estimate of how the flow is going. And again, it's not just the peak flow, right? Here's the peak systolic velocity in the carotid artery of that blood. on this patient's right side, it's up at 265 centimeters per second. It's pretty, reasonable. On the left side, it only gets to 90. So there's something going on the left side, but also the decay away here is much slower, right, than it is over here where the velocity drops down a lot faster. And so it's almost like it has some kind of resistance in it such that the decay has changed on that signal, right? So if you're gonna do some kind of Windkessel model of where blood flow is current, et cetera, the time constant for this decay has changed. And you can look at it obviously in this is sort of proximal, and then you look distal farther down the vessel to see what it looks like, and then compare those two. So this comes from a whole explanation of the use of Doppler or spectral Doppler, it's called. This is the brightness here is the intensity of the velocity. All right, so this is velocity on this axis, and the brightness of this line is essentially the spectral component. So how much of my signal is at this velocity versus this velocity, right? So you do that just by doing quick Fourier analysis over a window of that velocity signal, and you get a spectrum. Here, this is a very important application in the sense, this, again, I mean, it's hard when it's not moving to see what's what, but from this view, this is called TEE, this is transesophageal echocardiography. And I could show a picture, but it doesn't look too comfortable. It's like a snake, right? And so it's about, the probe itself is probably a centimeter in diameter. You can get a kid's probe that's half a centimeter, but an adult probe is about a centimeter in diameter. You spray the back of the throat of the patient with some kind of numbing agent, right? And then you put that probe down their esophagus, right? So they're essentially swallowing this probe. Not terribly comfortable. However, it gets rid of the problem of having to see through the ribs, right? Because now you're in the esophagus. And the esophagus, as you go by, the heart is right next to the esophagus. Right? So when you look up, there it is, right? There's nothing in between you and the heart. And so this is called transesophageal echocardiography. And it was probably one of the first intervention. It's not classic, it's not, what's it called? Anyway, it's not truly interventional because topologically you're still on the outside of the body, right? It seems like you're on the inside, but you're a tube, right? So you're still actually on the outside of the body. And so you put this tube down there, and it's probably the first type of ultrasound thing they stuck in people. So on this view, we've got the left ventricle down here, anterior wall for the left ventricle, and the left atrium up here. So the tube is underneath the heart looking upwards. I should have brought a diagram. It'd be easy to find one online, but and then sitting on top of the heart is this thing called the left atrial appendage. And it's almost like this extra atrium. So you have a bag, which is the atrium, and then on that bag, you have a little bag, right? Which is there's an orifice to go into this little bag. It's like, well, what the heck's it there for? And it's more than likely what it does is like a pressure release valve. Like if things get really high pressure, it gives you an extra little bellows to expand to try and relieve the pressure. That's just a guess. I don't actually, well, who knows what's from. Anyway, it fills with blood and empties with blood every heartbeat. And do I have a CT? No, I don't. Wait a minute, I think I might. Yes. Okay. Here, this is CT. And so you inject contrast and you image a couple of beats and put it together, and this is what you get. Left ventricle, that thing right there is the left atrial appendage. this is the left atrium, right? So you have the pulmonary veins coming in from the lungs, right? And they are filling the left atrium, which is this big sac above the left ventricle, right? The mitral valve plane is here, easily visualized there. And that gizmo right here is the left atrial appendage. And it's like, well, why are you so interested in the left atrial appendage? It is something that's imaged with ultrasound a lot, right? And as you can see, when the left ventricle ejects and you fill up the left atrium, this thing also expands out. It's like a bag on the side. So it'll double its volume or even triple its volume, right? And then when the atrium contracts, so does it, right? You can see a little thing, it contracted back and squashed blood out. And so blood is going to go through this orifice right here and out into the, back out into the left atrium. Okay. So let's go back to our ultrasound of this. This is the left atrial appendage. This is the left atrium. It's just sitting right off the side here through TEE. And what's really important is determining whether or not blood is in fact flowing between these two chambers, or is it getting stuck in the left atrial appendage? And if it's getting stuck in the left atrial appendage, the issue there is it can start to coagulate and you get a thrombus. And so particularly in atrial fibrillation, if this is not contracting the way you saw in that CT, it's just sitting there and it's a conduit. It's kind of a very distal conduit, right? It's a long way away from just where the blood is swirling around in the left atrium. And so that can lead to this coagulation and making a thrombus. And for those people who are in atrial fibrillation, 80% of the strokes that are suffered by those patients, people believe that 80% of those strokes are caused by thrombus that occurs in this thing, right? And so it's a really important feature that, you can image quite well with TEE. And so this is why you go to the trouble of sticking a transducer down the person's throat is, you can get a good view. Not always, but most of the time you get a pretty good view. So now we're looking at the Doppler spectrum. Remember the brightness of each one of these. This is time, right? And these are the heartbeats here. So time. Along each line here, I have a function, a spectrum with peaks that give you the power or the amplitude of the velocity component, right? So you get and this is right here, right? And I think this is at the pulmonary vein. Oh no, this is the LAA, sorry, this is the pulmonary vein down here. And you can see there's good velocity spectrum into and out of the LAA here. And so this is a super important measurement to proceed virtually any surgery and any intervention, right? Is to make sure there is not a thrombus in this person's left atrial appendage. You don't want to do surgery when there's thrombus in there, and you don't even want to defibrillate them if they're in AFib. And so it's a really important call. We can talk about resolution and time resolution and everything. This all boils down to false positive, false negative of, is there a thrombus in there, right? A false negative, if we call a thrombus or we miss a thrombus in there, it's a big deal. And we can talk on that. So what does it look like? Is this a movie? No, doesn't look like I've got that movie playing here. Maybe, let's see if this shice. Sorry to get distracted here, but if this is still online, it's probably worth seeing. Yeah, came back. Should have these things like queued up. Okay. Okay, here's the dynamics. There. All right, let's pop this thing open. Okay. I mean, it's, you see that thing basically here. It's fairly easy to detect that that's something that is not swirling and not moving, right? Granted, you know, there's a lot of noise and artifact and a whole bunch of things going on. But when you see something like that, you would call that positive. So the issue is, if you miss that, right, and the person's in AFib, the classic thing you do for somebody in AFib is you apply paddles and you shock them out of AFib, right? So basically you hope to sort of do a massive depolarization of the entire heart and all the chambers and everything like that with these paddles. And then the heart will reset itself and go back into sinus rhythm, where you have a very nice, you know, something coming from the atria through the His-Purkinje system into the ventricles, and now you have synchronous contraction. You do not want to do that if that thing is in there, right? Because it basically what it does is this starts contracting again, and it's going to squirt it out, right? And so this is the downstream cost of a false negative, right? So a false negative in this situation is I say, nope, it's a negative, there's no thrombus. False negative means there actually is a thrombus. And I make that call, they go defibrillate, and this squirts out and you get a stroke, right? So, you know, we can talk about what is our spatial resolution, what is our time resolution, contrast, all that kind of stuff. It boils down to how the physician is going to call it. Their dial changes a lot when there's something on the line, right? And so if they look at it, they're really careful. They're calling it negative, that it truly is negative. And so they'll, remember on the ROC curve, they can move their threshold, right, to decide what is my positive predictive value, what is my sensitivity versus my false negative calls, my, you know, negative predictive value. And they'll move their line such that they hit the rail, right? So that thing's almost zero. Now they've gone down in the sensitivity, and but they work at that rail, right? So you can make whatever ROC you want. You just have to push it as high up on that rail as you can, right, as an engineer. And because you ask, okay, well, what's the downstream cost of, you know, basically a false positive? And so I'm gonna call more people positive, and I might wrap up some people who actually don't have thrombus in there, and I call them positive. So what's the downstream cost of that? Well, normally what happens is they just go into the protocol of people who are positive, and that protocol is like, we're going to put you on a week of antithrombotic drugs. And you come back and we'll take a look again. If that thing's dissolved, then we'll proceed. If it's still there, we're not going to proceed. And so that carries much lower risk than getting somebody back in sinus with thrombus in there. Now, it's still risk. There's still risk in the sense that, you know, anticoagulation will promote bleeding. So you can get, you know, bleeds in your guts or, God forbid, in your brain, right? Which are just as serious as strokes, but the probability of that occurring is much lower. So the physicians set the dials, right, of their costs with your ROC curve, right? And they'll just roll to a point where they're comfortable, you know, making that call. So that's yeah, thrombus. You can imagine if you come back in 2 weeks and that darn thing's still there, right? The question is, what do you do then, right? You know, the person's still in AFib and they've got a thrombus in there. You give them drugs. You can imagine you could go in and, like, with a device, right? This is where, you know, medicine gets really fun, is like, oh, we're gonna make a device that I can sneak up into the left atrium, probably come across the right system, go up in a vein, go up into the right atrium, poke through the septum, right, with some kind of needle. So now I'm in the left atrium. And so my device is here, and I'm looking down in here, and I'm going to go and suck that thrombus into my device and then take it out. Right? So we would do that under ultrasound guidance. You would have these images in real time going as you did that, right? And crossing the septum is done a lot under ultrasound guidance. So you make sure you're placing your needle in the right, not just the right position, but also the right orientation when you push, right? You don't want the needle, if you're going to cross the septum between the right atrium and the left atrium, you don't want the needle, say, to be pointing down. You go bloop and you're going to the esophagus, that would not be good, right? So you make sure you're in the right orientation, and then you cross and go in and get that thing. And hope to heck you don't see it, like as you're just getting it off the wall here, go, that's not good, right? And in fact, you can make, they have some devices that you stick basically distal, downstream. You can put like a little mesh, like that stays in a large vessel, such that if anything breaks off, it'll get caught by this mesh. And then you, just like you're a fisherman, and you get that net out at the end of the procedure. Yeah?
Pull the thrombus all the way back through the septum and all the way through the entire path, all the way out.
Now you would try and get that thrombus into your device. You would locally try and suck it into something, right? And then take the device out. Yeah, yeah. You know, I wouldn't want to like grab one end of the thrombus and start dragging it. That's probably a bad plan, because you probably lose it one day. So, okay. So that, and we'll see, maybe I'll look for that procedure for our next lecture. Okay. Okay. This CT, interestingly enough, comes from a Siemens, and it probably took 3 heartbeats to make this movie, because their detector array is not the super wide one. It's about, I want to say 6 centimeters or something. And so they have to start at the top and kind of raster down through the heart. So it takes a couple of beats, and then when you put them together, you get this. And it looks like that person had the same beat every time, because I don't see any seams or any kind of stitching stuff together. It looks pretty good. And spectacular time resolution, right? For CT. This scanner, sorry to go off into CT, this scanner has 2 detectors, 90 degrees apart. So it's got, not only does it have, you know, a 6 centimeter detector with 64 slices or whatever, it's got 2 of those. They put another one at 90 degrees. So now you can get the image done in half the time. So you get these crazy high resolution pictures. So remember, I talked about this with a lot of hand waving. Here's a very nice diagram that maps the 17 segments that we saw in the classic echocardiography views to the vessels that feed those segments, right? And so if you see some big abnormality here in the 2-chamber view on this side of the heart, it is most likely the right coronary artery that is the culprit vessel, right? And so again, you can see not only are these segments big, the territory fed by the artery is multiple segments, so it's even bigger, right? So, and then these striped ones that can be one or the other or both can feed that area. And humans, they miss the opportunity to have a lot more collateral flow. It would be great if you had like 6 coronary arteries and they all cross-fed different parts, because then if one goes down, it doesn't matter that much. Not the case in humans. You can have, look at this chunk here. If this vessel goes down, it's gone. That whole chunk's gone, right? And it's a big problem. Whereas it would be nice if it was cross-fed by something else. Certain species have much more collateral flow than we do, like dogs and things like that. But okay, so one of the things that echo has been used for historically over 30 years is to try and detect the onset of muscle wall abnormality when you stress the patient. Okay, so you can put the patient on a bike, you can give the patient a flow stress agent like adenosine, which dilates all of the vessels. Exactly the same stuff we did with SPECT, right? But now in stress echo, you don't really measure the flow in the tissue. What you're going to measure is the muscle contraction. You're going to watch it change as the stress goes up, right? So classically what's done here is they use a stress agent called dobutamine, which is much like adrenaline. And when you inject it, even though you haven't run anywhere, you haven't done any exercise, your heart contractility goes up. Your heart rate doesn't, it goes up, but not to an exorbitant amount. But just the contractility really goes. So it's pretty cool in some ways. Like if you ask somebody to hold their breath, they can do it because they don't have a lot of demand from their skeletal muscles. The only muscle that's really going is their heart. And they feel a little weird. They feel a little like you would feel if flight, or fight kind of thing. And where you just fell in love or something like that makes your heart beat. And so this lecture is a really good lecture. This guy's famous for stress echo. And so we have this classic system of segments. And if you're doing scoring of is the muscle contracting normally or not, there's kind of 5 buckets it can go in. 1 of 5 buckets. Looks normal. It's slightly down in that it's not normal, but it's not stationary. Akinetic is when the muscle actually is stationary. It just doesn't contract, right? So those 3 are like, I'm contracting 20%, 10%, 0, right? So, in terms of shortening. Dyskinetic means it's going the wrong darn way, right? So when it's supposed to be contracting, it's actually getting stretched, right? And you can imagine that if one side of the heart's really healthy and one side is not, when the side that's healthy contracts, it will blow out the side that is not healthy, right? And so that's called dyskinesia or dyskinetic. And then aneurysmal means that the tissue's dead and it's expanded. So it just looks like an aneurysm. And then this isn't done a lot, actually, like this quantitative thing. You try and do this for papers. It's like when you're trying to evaluate, does my, new echo machine perform better than that echo machine? So how are you going to measure that? You do this kind of analysis. And each doc in each segment gives it a number, okay? And then you come up with this wall motion something index, wall motion something index. And if it's like 17 times 5 over 17, you got a problem, right? If it's basically 1, you're good. Every segment's good, right? Yeah, I think that. So here, like, does this play? Oops, sorry. I gotta go out of edit mode. Yeah. Oh, that's a picture. That's a picture. Wait a minute. Okay. Should be up top. Okay, here we go. Let's do this. Okay. So you can see here, he's labeled all of these with ones. That's a 1. And then here, he's labeled these with a 3 because they're, really not making much happen. These get a 2, and then these are all 1s. Now, this is, I like this in the sense that it's very honest, right? You look at this and you go, man, I don't know what the heck's going on there. Half the time it's in total darkness, right? Total shadow. But, when you look at the other orthogonal views, you can anticipate what this is if you're looking at the short axis view of that as well, right? And so that's how these things are done. I'm just going to keep this on since we're here. So here's an example of a patient who doesn't look entirely normal, right? If you look at that, oops, my bad, sorry. Right? Again, this looks a little down here. The whole chamber itself stays kind of open. Here you have a function that's down. So question is like, well, why is this patient abnormal? And what we can do then is compare those images that we just saw. And then it turns out that these images were obtained after the patient got off a bike, and then they imaged the heart. So this patient was on a bike riding. And when you compare this to this is what the patient looks like at rest. So you can see there's a lot more contraction occurring on this side specifically than here. Here you see the inner wall versus this. And so under stress, the stress has produced this wall motion abnormality, right? So the class, 1 to 5 has changed during the stress. And these images are very, quote unquote, honest in the sense like they're not the same images you see on the GE website or whatever, because they're sort of natural image quality. Part of the difference in image quality, obviously, is the body habitus of the patient, right? I mean, if the patient is a large person and there's a lot of fat, under the skin between the ribs, you can't get right on the ribs. That's why when you go to these trade shows, the people that are lying on the table when they're demoing these things are like ridiculously fit, thin people, right? And so you get these amazing pictures. But in reality, as 1, the target gets farther away from the transducer, and 2, you can't get the transducer up to the ribs, then you got a problem. Then eventually, if the person has a BMI of like 28 or over, you usually just take them to MR, because then you can see with radio waves, you can see right through all that. Right. But the point here is that we have some kind of quantitative difference in rest and stress. And then that is indicative of ischemia. And so classically, you would say, those are the people that should go to the cath lab. And you should then look in great detail at their vessels and decide, do I open that vessel with a stent, right, to make it wider? All of this got thrown in, into a strange box with the ischemia trial and with the PROMISE trial, et cetera, where it showed that, maybe you should just give them optimal meds as opposed to the stent. So it's sort of like for people who are stable, by definition, this person's stable, they're on a bike, right? So we're able to bike. So do you just give this person optimal medical therapy, or do you go in and stent them? So I think nowadays it's kind of a decision for the person. So like for someone who is capable of making those decisions, then you should just tell them the options and here's how it goes, right? Some people don't want to make those decisions. They want their doctor to make that decision. But anyway, that's a stress test, okay? And this is very good, honest quality images. And you can imagine that if you go in and you want to really quantify the difference in the ventricular function from this to this, you've got questions like, is it exactly the same plane? You know, did the heart change its shape, etc. So, but then an expert, when they're viewing it, there's no question you can see a difference, right? And so that's it. I think a pretty cool application or project could be, teaching a deep learning network to look at these movies, right? Have the underlying MR and CT and things like that. And then the network itself just looks at the movie and tells you what's going on, right? As opposed to going down and classically drawing borders, calculating radial thickening, all these numbers, which are susceptible to huge errors, right? So, but when you look at it, it's fairly obvious what's going on. So that's what deep learning is actually good at, right? Just like figuring out if it's a cat or a dog, right? And so it's the same problem, you know. Okay, let's make sure I get back to the right place here. What time are we at? 10:45. So we got like 5 minutes. Oh yeah, I've been talking slow. Okay. Oh, here we'll just do one more thing. This movie, which I won't go back there, but it takes too long to get there. But does anyone notice something different about these ultrasound pictures? In particular, look at the intensity of the blood inside the chamber. It's like, what's going on here? That all of a sudden we have white or bright blood images, right? And this is really cool. And they do this, I don't know if, I don't know what percentage of the time they do it now, but you can get just off the shelf micro bubbles, and they're essentially tiny little bubbles, and you put them in a syringe and you inject them into the patient, right? And these, I'll remember, but they're micron style bubbles. And so they just get absorbed. They don't cause any deleterious effects. However, they are hugely echogenic, right? In the sense that you get 100% reflection off these bubbles. So if you have a whole bunch of them in the blood, then they show up as this highly echogenic object. And so people claim you can actually measure perfusion in the tissue by whether or not these bubbles are in the arteries and veins in the tissue. I'm not sure I believe that. But certainly it changes the contrast at the endocardium. Whereas, prior to injecting the bubbles, you could have had a very difficult time seeing that border. Post bubbles, it's pretty simple. So you could do it in real time. You just start taking your data. Looks terrible. You can't see a border in the heart. You inject the bubbles, and it doesn't last long. You inject it, and then in real time you can see it. Okay, I'll get some data on what those bubbles look like for the next class. Are we doing echo applications next on Thursday too, right? Yeah, okay, so we can roll over a little bit. Okay. All right, so I'll stop there today. Any questions? Everybody good with the project assignment and the partners and everything's going well? No issues? Okay, terrific. All right. And I'll see you on Thursday.